Welcome everyone again and good evening. And thank you all for joining the Sadhguru Center for Conscious Planet Speaker Series. My name is Safida Hariri. I am the program manager at the Sadhguru Center, and I'm also an instructor in anesthesia at Harvard Medical School. So the Sadhguru Center for a Conscious Planet is a multidisciplinary center integrating various disciplines from neuroscience to yoga and meditation with the aim of bringing together researchers, global experts, and thought leaders, and drawing from the strength of science and spirituality to better understand and enhance consciousness, cognition, and compassion through research, education, and outreach. Today, we are very fortunate to have Dr. Shahla Siddiqui as our speaker. She is an assistant professor of anesthesia at Harvard Medical School and a faculty member at Sadhguru Center for a Conscious Planet. With a medical degree from Aga Khan University in Pakistan and a master's in medical ethics from the University of Singapore, Dr. Siddiqui did her anesthesia residency at the University of Maryland and a critical care fellowship at Columbia University. In addition to clinical work, she has an active research career in areas including interprofessional education, health science, qualitative research, ICU burnout, sepsis in the ICU, the genomics of sepsis and ICU outcomes. And she is also passionate about medical ethics and related topics such as compassion in medicine, an area where she has several active projects. So we are very glad to have her today to present about the history and the future of compassion in healthcare. Shahla, the floor is yours.
Thank you so much, Sapide. So I just wanted to give a little bit of an introduction to myself, not adding anything more to what Sapide has said, but just trying to link in the journey to compassion from where I started. And to do that, let me just share my screen. So about 20, 25 years ago, started doing medicine in my home country in Pakistan, and then came to the US after that, did my training here. And then life kind of took me back to Pakistan, to Singapore, where I did I was practicing as an anesthesiologist and intensivist. And during that time, a lot of the work that I was doing was with patients in the ICU, elderly patients, a lot of moral distress, seeing a lot of issues between patients, their families, and end-of-life issues. And I got very interested in studying this from an ethical basis and from a point of view of an ethicist. I was also working with the ethics committee at that point. I was an ethics consultant, and I decided to pursue a master's in clinical ethics at that time. Initially, it was a PhD, but then I ran out of funding, and so it landed up with a master's. But my thesis was using social psychology theory to understand the perspective of family members of elderly patients in the ICU. And this was most interesting to me because of all the aspects that I faced during my clinical practice. And also the ethical consults that we would get on the ethics service. I attended some extraordinarily helpful courses across the world, got very interested in it. And so I started learning more and more about how perspectives of family members differ from those of physicians and clinicians in the ICU. I also had personal experience. Both my parents were in the ICU, and from a very young age, when I was just a medical student, I had actually seen my mother in the ICU and seen ICU clinicians taking care of her. So I had a personal perspective as well, which I wanted to build in and unpack into my learning and my practice. And the word compassion, although was not very important at that point, it didn't come up in life. One doesn't think about these things. But when I read more and more about compassion, what was being defined as what was the main problem and the issues that were being faced seemed to fit the definition of what is encapsulated within compassion. So I wanted to go over some of that background and where history seems to have alluded to compassion, and then link it to what we are doing currently. And then I want to take you on this journey to what we foresee in the future with compassionate care, especially in relation to the ICU and healthcare. I wanted to bring in a little bit about moral theory, although I'm not an expert. I have some experts here on the call, but I wanted to bring up a little bit of what I have read. And I also wanted to, in the end, share my research interests, which are 3 studies that I'm doing, which link to similar issues. And I won't take up too much of your time. The talk should be around 35 minutes, and then happy to have discussions on comments and questions. So the title of my talk is The History and Future of Compassion in Healthcare. So this is a very famous painting by Samuel Fulders hanging in the Tate Gallery. I've actually seen this. It was painted in 1891, and it's called The Doctor. And when you look at this, you see a physician sitting next to a patient who's a child, and he's obviously not doing well. And there's a very concerned parent, a crying mother in the background. And you see the look of consternation, you see the look of worry, the look of concern in the physician's face. And this painting is simply called The Doctor. But when you just stare at it, and if you look at it in real life in the gallery, a lot of emotions go through your mind when you actually go into this painting. And one of them is what you would call compassion. Because this physician is clearly immersed in the suffering of his patient and the patient's family. So the word compassion is ubiquitous in modern healthcare, yet few writers agree on what the term means and what makes it an essential trait. So we don't really know what it means. Although many modern writers have assumed that compassion is a universal and unchanging trait, the term is extremely new to healthcare. So surprisingly, compassion wasn't used in healthcare until 2009. And the concept could have previously existed under another name. For example, this painting, painted in 1891, clearly shows what we call compassion now, but the word was not used in literature or healthcare before 2009. Now, if you look at this little mural that I made with a background and a historical background of medicine, you'll see that you have the Ayurvedics looking at patients and treating them a long time back, many centuries ago. You see the Greeks and the Romans taking care of patients. This is a painting of Ibn Sina or Avicenna, who was the father of ancient medicine. In Egypt, and he is taking care of his patient. And then you have the ancient Chinese, traditional Chinese medicine. All these practitioners have something in common, and that is that whether they are called physicians, healers, messiahs, they all had something in common, which was they were trusted to deliver compassion and sympathy, empathy, and healing to their patients or people who went to them. And interestingly, some of them were not known as doctors or healers or physicians. They were actually religious figures at that time or spiritual leaders who were also scientists, scholars, and they would be able to take care of patients because of their wisdom. So I will thus present in this talk a historical approach to understanding compassion, as well as weave several influences of moral and ethical philosophies. I will end with how compassion is pivotal for the future of medicine and healthcare, and where my research stands in this construct. So as I said before, religion has complemented medicine in similar ways in many cultures and in nearly every age. And compassion and humanity are the basis of this intersection. So the reason why people would turn to religion at that time was because there was no formal structure of medicine or healthcare. And these were the very wise, the very scholarly figures in their religious faith who would lead medicine, who would lead healing, and they would do so because of partly because of what they would think as their role of being compassionate and being sincere in their healing. Even today, many people view medical concepts and treatments from a religious perspective. For example, share. For example, in the Ayurvedic tradition, way back in 800 BC, to feel someone's suffering, you actively engage your own sensitivities, nervous system, and emotions.
Shahla, I'm sorry, we are not seeing your screen. I think you might need to reshare.
I'm sorry. Are you seeing it now?
We can see it now. Thank you. Perfect.
I'm sorry about that. So in the Ayurvedic tradition, 800 BCE, it was important to feel someone's suffering. You actively engage your own sensitivities, nervous system, and emotions in mimicking the feelings of one who is suffering. That was primarily important. Avicenna or Ibn Sina in 980 AD said that he's the ancient father of medicine. He said that the purity of body and mind through compassion and justice is important. The Greeks and the Romans were mostly important at that time. For example, Homer and Hippocrates, the father of modern medicine, said that the concept of divine retribution and need for morality and empathy is a means for purification. And then the traditional Chinese medicine, Su Wen in 206 BCE, said that the spirit is responsible for benevolence, which is loving kindness, awareness of suffering, empathy, compassion, and tolerance, and serves as a reservoir for ideas that bring meaning into life. So here we see the intersection of compassion, or what was thought of as compassion and kindness in medicine, and the bond between medicine and religion or healing. The influence of religion and spirituality in medicine has been important. Compassion embodies an ideal of character that is grounded in human dignity or respect for persons. And this was the moral basis of many religious philosophies, as well as the grounds for the work of the German philosopher and ethicist Immanuel Kant. He's a father of many principles and ethics that we learn about. And I will go a little bit into this, although, as I said, I'm not an expert in moral philosophy. But one of the most important work of Kant is the central philosophical concept of the categorical imperative, which links deontological morality with unselfishness and compassion. So our capacity to reach out beyond ourselves into the lives of others allows us to work together for a common good and forms the basis for human success. And it is a moral imperative to reduce the suffering of others and not cause them harm. Now, if you look at compassion and morality, another scholar, Schopenhauer, said that compassion is the basis of morality. So doing good or doing our duty is basically based on our feelings of compassion and kindness. However, here's a little bit of criticism of the word compassion. If you unpack the whole framework or the construct of compassion, if it's simply led by emotions such as in empathy and sympathy, there is a problem, because the problem is that a problem of being biased, of being visceral and prone to fatigue. For example, if a child is asking for something, if we are purely emotionally involved with the child and only have feelings of empathy or sympathy or kindness, and we give in to the demands of the child, that may or may not be compassion. There's something more to compassion if you unpack it, more than empathy, more than emotional feeling towards something. So in our daily practice, we feel a lot of feelings, we feel a lot of emotions, but compassion is not just feeling those things. When compassion is combined with morality, we then have a duty towards others and ourselves which values and respects their humanity and transcends just emotions which can be biased. So emotions can be biased. Emotions are prone to fatigue. Emotions are good. Emotional intelligence is good. But just calling compassion emotions is not enough, because compassion is more than that. And it's linked very closely with the principle of morality and moral justice and our deontological or our duty of care towards our patients. So if we fast forward to modern times from ancient medicine, where does compassion stand? So becoming compassionate, a new model for healthcare in the 21st century. So people from England especially would recognize this. This is the famous Francis report. And before this, there were few references to compassion. Even before the 21st century, there were very few references in literature. However, there was a very sharp spike in the use of the word compassion in 2013, when Compassion in Practice was launched and the final Francis report was published. So a little bit about the Francis report. This was a report led by Lord Francis, who was a solicitor at that time, and he basically looked into this one NHS service, the Mid Staffordshire National Health Service Foundation Trust, which had an abnormally high mortality rate. So here patients were dying at a much higher rate than the national average. And the report basically found that there was an absence of compassion in that trust. And the patients were dying in their own feces. People were not being treated with kindness. Secretarial staff were triaging dying patients in the ER. And there was just a lack and indifference of care towards these patients. So soon after that, there was a centrality of compassion in healthcare based on recommendations of this report. And even the Prime Minister of UK at that time said that people should be not just hired for their compassionate spirit and actions, but also promoted based on how compassionate they are. So basically, compassion became very central to modern healthcare. And the effect of this Francis report rippled across the world. And ethics services, as well as the trusts, as well as CEOs of hospitals started looking at this aspect of medicine and healthcare with greater detail. And this is really what families have been saying all along, that there is a disconnect between what we consider it's like communication. All doctors think they're great communicators. I don't know about nurses, but doctors do. And when you go and do studies and look at what families may think, especially in difficult dilemmas or in end-of-life care, you'll find that it's not the view held by the public. So there is a disconnect, and there is something that's missing. And in my thesis that I had done, I found that missing link seems to be an aspect of emotional intelligence, presence, and compassion. And I will talk about that in greater detail in the following slides. So references have sharply risen since 2015 in medicine. Today, the word compassion remains overused, so we've swung the other way. And it's little understood. So, we do need to understand this in a greater way and know how to teach it to our residents and our trainees. We also need to understand it in order to role model it better. If we are to continue to employ it at all, we need to be aware of the concept historically, socially, and politically, and avoid using it to draw assumptions about the moral character of the individual clinician, but of the action taken based on duty and virtue. So in the Francis report, it was found that it wasn't that these were evil doctors and nurses all collected in Staffordshire. It was found to be the system was made in a way that there were severe bounds of, even if the people felt emotionally upset, morally distressed, there was nothing they could do to overcome. So their duty of care was severely hindered by the way the systems were in place. So this book was also very important. The English Institute launched this book. It's called The Culture and the Politics of an Emotion. They took compassion as just an emotion, but there's a lot behind it. So it's a three-dimensional word with a lot of implications and innuendo. Now, I mentioned the word presence, and I find this very, very important and very crucial. And this saying, this quotation I took out of Zen thinking, which is that presence is infinite, unbound by anything, and it is open, spacious, silent, and empty, forever aware, focused on nothing, and yet intrinsically in tune with the totality of its environment. So this is a feature of whenever you have a successful connection with a family member or even just anybody, especially when emotions are rife and situation is dire. When you have presence of mind, presence of thought, presence of soul, it's very important to define what this is, because you cannot teach this. This is not something that comes from reading. it comes, or from a course. You can't just pass a course or a module and then say, well, I have mastered presence, because presence is something that comes with experience and emotional intelligence. And it doesn't have to be correlated to your age or any kind of other demographic. Presence can be present. I've seen conversations in the ICU where it was just a silence, but there was a huge connection. And I have been present in presence where there have been just the value of not speaking is very important. And this presence is something which is very undervalued in medicine. I've also been in family communication scenarios where there's been too much talking and the families are left bereft of any understanding of what has happened. Nothing is registered, and just not been a connection between who's speaking and who's being spoken to. So this paper came out in BMJ in 2019. What is clinician presence? A qualitative interview study comparing physician and non-physician insights about practices of human connection. I'm surprised it was published, but it's an amazing qualitative analysis of what people understand as presence. Clinician presence is best enacted through purposeful intention to connect conscious navigation of time and proactive management of technology and the environment to focus attention on the patient. Everyday practice or ritual supporting these strategies could support physician self-care as well as physician-patient connection. And the authors found that actually connecting with their patients, even if it's for a few minutes of every conversation that they have, can actually improve their self-wellness, their own self-awareness, and their feeling of well-being. So this was a surprising finding, that the presence not just helped the person who was the recipient of this presence, but also the person who was giving out the presence. There's a yin and a yang to self-compassion or presence, which means that there are two aspects to it and opposite poles. Using caring force to change ourselves and our world is important. And the yin and the yang is, the yin part of it is being with ourselves. So being comforting, soothing, validating is important, not just to ourselves, but the yang is for whoever the patients are, their families are, it's acting in the world. So it's the outwardly manifestation of compassion, which is protecting, providing, motivating. And if ever there is an image or a picture I have of compassion, it's of a deity holding the world in nurturing, loving arms. And for some reason, that deity is female. I'm not sure why, I'm not gender biased, but the connection between a female or a mother, the aspect of somebody who's nurturing seems to be a feminine quality. It may be present in men. So there is a whole movement in European ICUs, in the European Society of Intensive Care Medicine, called feminization of the ICU, which doesn't mean you hire more women, which is, for me, that's a great thing. But basically it means that for the past 20 years or 2 decades, we have been reveling in this very masculinized version of being aggressive, confident, unemotional, matter of fact, and that makes us stronger and is respected in our field. But the nurturing, loving, compassionate, emotionally aware, kind aspects, also known as derogatorily as the soft skills of medicine, I call it derogatorily because that puts it already in a box where residents feel that they really don't need to open that box till they really have to. That box needs to be taken a little more seriously. And that comes from this yin and yang of self-compassion, not understanding how it manifests within ourselves as well as manifests with the world that we deal with. So now I come quickly to where I stand with my research, with this little bit of background. I'm sorry I had to take a Shutterstock picture from Google for this, but I couldn't find a deity holding the world in nurturing arms other than this picture. But I tried to make my research focused on different aspects of compassion. And so I'm doing 3 projects, which are well on their way. Some of my collaborators are on this call, and I thank them from the bottom of my heart for their expertise. The first study is what is compassion for our patients, to understand what compassionate care means. Second is what is compassion for our peers. And the third research focus I have is what is hindering compassion within ourselves. Because I can read up a lot about how to be compassionate and I can act compassionate, but if I go like in Staffordshire and start practicing in a non-compassionate, by the way, the opposite of compassion is negligent or is indifferent, sorry. So in my life, I tried not to be indifferent. I don't try to be compassionate because that's very hard and who knows what it means. But I try not to be indifferent. And if you're not indifferent to people around you or yourself or just your families, there's no way you can be compassionate. So it's important to overcome the opposite first. So the first study is the future of compassionate care in the ICU. This is a picture of a physician in Italy. It's become very famous on social media during COVID. It's a physician sharing the suffering and grief of a dying patient in the ICU during COVID. This is one of the mentors that I have for this study. His name is Professor Arthur Kleinman. He's the head of social psychology at Harvard Med School. He's written a book called The Soul of Care. And after reading this book, I became driven to trying to unpack what compassion is. He actually took care of his wife. In this book, he writes about it, and she was dying of cancer. He writes that the contemporary crisis of caring globally is implicating the soul, implying medicine and healthcare has become soulless. They fail to engage the most deeply human experiences that require care, not management. So when we say health management, that takes away a lot of why we became doctors, what the altruistic reason is, why doctors and nurses are in this profession. And about 60% of what we do is around altruism, even if we don't call it that. And I feel that health management and the way medicine is practiced now or is managed takes away a lot from that. We need soul to specify the human quality at the heart of care in order to animate the souls of patients, family members, and clinicians. So he, in this book, writes about the soul of human, which is a human quality at the heart of care. In this study, which is called Compassionate Care in the Intensive Care Unit, these are my co-investigators. Dr. Beth Lown is from the Schwartz Center for Compassionate Care. Dr. Christiane Hartog is the head of ethics at the European Society of Intensive Care Medicine. Dr. Michael Newrock is past chair of the anesthesiology section at FCCM, which is the US equivalent of the Society of Critical Care Medicine. Professor Gillen is here on this call. I'm very honored. He's the chair of ethics, past chair of ethics at Imperial College. I attended several of his courses that he holds at Imperial College on ethics. Dr. Subramaniam is here on this call, and he's the director of the Sadhguru Center that kindly invited me for this talk. He's also mentoring me, and this study is part of his center. And then, of course, Professor Arthur Kleinman is part of this study. In this study, it starts out, there are three prongs to this study. One is a mixed methods survey that we sent out to about 60,000 clinicians, both nurses and doctors across the world, both from the European Society of Intensive Care Medicine and the Society of Critical Care Medicine. The aim was to use a modified version of this 11-point Schwartz Compassionate Care Scale for self-assessment. And the second aim is to assess a broader understanding of compassionate care by eliciting free text comments on 3 ICU case vignettes. And these are real life case vignettes that I came across in my clinical practice, which deal with compassionate care in the ICU. And once this survey is done, we're going to do a focus group of participants who have volunteered from across the world. So we have participants from India, Europe, Canada, and North America, as well as South America. And we have made 2 videos that we will show, one showing compassionate care in the ICU and one showing lack of compassionate care in the ICU, and as well as systemic bias. And we are going to try and portray that to our participants and then ask structured questions based on that. We will then do a qualitative analysis and something called a semantic analysis to unpack that with the help of Professor Kleinman and other experts in the area. So this is our methodology, the survey, the free text replies, the focus groups. We're going to use the cases, the qualitative situations, and form a theory on understanding of compassionate care in the ICU, how the world of clinicians and nurses looks at it from all over the world. How do they think of what compassionate care is? And The other study that I'm doing is for peers, and this is called Forging Interprofessional Education in the Perioperative Setting in the Time of COVID-19. This study is supported by CERTAIN, which is our educational arm, as well as has a grant from the Healthcare Delivery Science group here. The previous study on compassion is also a recipient of the John Hedley White grant from Harvard. In this study, basically we're using emotional intelligence tools to navigate difficult situations in the perioperative setting. And here we're trying to see how real life cases of interaction with each other can improve our interpersonal relationships. And we are using anesthesia residents, surgery residents, and nursing participants in sessions which are held once a month, where we discuss real life scenarios using tools of emotional intelligence. And the goals are to increase emotional awareness for better understanding of each other's perspectives, to improve emotional awareness among the trainees as well as the nurses, and to identify strengths and areas for improvement for this curriculum. The basis of this is that we understand that IQ is just the tip of the iceberg, and it's really our emotional awareness and emotional intelligence which helps us improve our interpersonal relationships and compassion towards our peers. And as we know, as I tell my trainees, that having the greatest of skills is just a given here, but it's really how employable you are depends on what your emotional intelligence is, or how interpersonally connected you are with your peers. The aspects of emotional intelligence that we seek to develop in this study are self-awareness, social awareness, self-management of our emotions, and relationship management. And all of this leads to better motivation and better purpose in what we do. And I use this Chinese metaphor, this picture that I came across, and I love it. I use it in every session when I lead the session. It's a picture of a man pulling up a woman. The man doesn't understand that the woman cannot help herself because there's a serpent in the cave and she's not helping herself up, and he's frustrated because she's not helping herself up. The woman doesn't understand that the man has a boulder crushing him down, and therefore he's not able to help her as much as she would like. So here you have two people who are pressed by different pressures, and their perspectives are only involving themselves, but they don't see the perspective of the other person. So really, interpersonal relationships are based on what the other person's, what you think is the perspective of the other person, and that can be improved by your emotional awareness as well as your own self-awareness. And what I spoke about, presence, can actually be improved by practices of yoga, practices of mindfulness and meditation. And you can actually practice that while you're talking to your patients and improve presence by just meditating on what they are saying and just focusing on one thing and trying to be present in what they're saying. And then lastly, I'd like to talk about a study that I'm just starting and trying to find funding for. It's called Unconscious Bias in Healthcare. And it's based on end-of-life care in the ICU. It's in collaboration with our own research arm called CARE and Insight Core, which is giving me data on about 1,800 patients in the ICU who all died with a DNR order in place, which is do not resuscitate. And these patients died before COVID and during COVID. We're looking at their end-of-life trajectory, and we're looking at how end-of-life care differs. We're looking at demographics and seeing if there's any difference based on ethnicity or race. And we're also trying to get funding for this study. The specific aims are to find disparities in end-of-life care in the ICU based on the ethnicity of the patient, and this will include the following scenarios: examining the patient factors leading to DNR and comfort measures in the decisions in the ICU, examining the processes involved in end-of-life care in the ICU, examine the physician and team factors involved in DNR CMO decisions, assessing family involvement, assessing appropriateness of analgesia during CMO care. I don't know if any of you were aware that around Christmas time, there was a physician, a Black physician who died of COVID in the ICU in the US, who alleged on social media that she was not given adequate analgesia and she died in pain. So that moved me a lot to think about these things, and I did a literature search, and then I came up with this, and I found collaborators across BI in the medical ICU as well as the surgical ICU to help me with this study. It's harder than I thought it would be because it's a very difficult topic to navigate, but I'm trying to find like-minded individuals and helping me with this. We aim to provide baseline data for looking at disparities in this particular scenario, and then moving forward with doing interventional behavioral or teaching aspects where we can unpack the unconscious bias and then look at our data again. So in conclusion, a lot of what I do is based on what we call soft skills, which again, I don't like that term, but I'm forced to use it because that's what ACGME calls it. Luckily, they have moved to calling it milestones. And for those who don't know, ACGME is our training, the authority for our training programs in the US. And basically it's kindness research, looking at the behavioral and the social aspect of how we can incorporate, because having been on the other side, I know that when patients come to ICUs or patients come to us as physicians and clinicians or are in dire circumstances, they of course want our skills, they want the best from us, but they also want the connection and they want kindness and they want more than just words and skills. And often these are the physicians and the nurses who make the greatest impact to their life. And as our CEO mentioned, as an organization, our everyday is rooted in healing and compassion, which means that we need to take on the challenges of systemic racism, bias, and injustice with passion and conviction. And we can, we are, and we will. And he says that I assure you that we will continue to rise to meet what this moment requires for us for as long as it takes. So with that, I'd like to end the talk, and I would love to hear your comments or questions.
Thank you very much, Shahla, for this intriguing presentation and also for working on this very much needed topic. I feel what you shared about lack of presence and care in healthcare is also present everywhere else in the society. And it will be really wonderful to see how we can nurture this aspect in not only medicine, but also in education system and all other aspects. I think it's very much needed. So thank you for that. So if there are any questions, please go ahead.
Hi, Shahla. Thank you so much for your talk. I just thought I want to clarify a little bit about masculine, feminine, male, female, right? So I know where my source of information, you know where my source of information comes from about these things. So just want to reiterate that masculine characters or feminine characters doesn't mean male or female. A male can have both. A male can have more feminine characters than a masculine. There's nothing wrong in it. So I just wanted to clarify that issue. But excellent talk about contemplating how this has evolved into where we are right now. So yeah, I would love to hear what Nancy and Dr. Anand have to say as well.
Hi, this is Nancy. I'm actually on my iPhone, so it's a little challenging. I wanted to send you a chat and tell you how spectacular that was.
Oh, thank you so much, Nancy.
And what I particularly was just struck by was the way you brought in the whole history of all of the healing traditions, and the way, you know, you just made it all totally universal and therefore approachable from so many different dimensions. That was spectacular. And the way you have made, sort of turn this into 3 research, you know, focuses that each one is just really opening doors. So I just want to congratulate you on your work. And given that at this point in time, you know, one of the many issues we're dealing with is biases. And I would love to hear what you have to say about that. You know, you touched on it, but, you know, what other thoughts, you know, have about how sort of compassion as the, I don't know, antidote to bias or something. So I'd love to hear your thoughts on that.
Thank you so much. And of course, I'm inspired by you and your whole life. So everything you've done has been inspiring and dealing with similar issues of compassion. So you're a role model for compassion for everybody here.
Thank you. Thank you.
So I feel that compassion and bias are very closely linked, as was shown in the Francis report. And that's an exemplar for, I think, many places that we work. And I've had the opportunity, because life has taken me floating across the world. I've worked in the US, where I trained with excellent clinicians as mentors. Dr. Sladen is one of them. And then I moved to Pakistan, and I worked in Pakistan with all its various restrictions that we had as a woman working in the ICU. Then moved to Singapore, where there were other kinds of aspects of clinical care and expectations from society. And then moved back to the US. And I also have family in the UK. So I've kind of traversed the globe, where my family are all physicians. So I kind of have an influence, or I've been influenced by the biases and the hindrances to compassion in every aspect of global health and global medicine. The reason I call it hindrances to compassion is that the way the systems are, and as you noted, if you read history, you'll see that the historical figures had no hindrances. There were no systems in place to stop them from being the messiahs or the healers or the faith, the person that people would go to for their soul, the spiritual healing or their physical healing. That's why religion is so closely linked to doctors or medicine. How we have fallen in that is that healthcare itself has held us back. In the Francis report, what has come out is that people actually felt the need, but they didn't speak up. There was no way that they could speak up. So when I go around looking and talking to people about bias, and when I'm very pointed and I say, well, do you treat your African-American patients differently at the end of life, or when you are prescribing analgesia to them? Nobody will say yes. I mean, no one. And I feel part of it is that we are not trained to recognize what we call bias, and we are not trained to recognize what we call compassion. And then when we don't have compassion, when we are indifferent, which I see every day at all levels, and I used to see that in myself, and you have to actively get rid of that. I think if we focus on the word indifferent, that makes more sense to us than being compassionate, because that sounds very lofty. So I think bias is to answer your question directly, bias is very closely linked to why we cannot be compassionate or why we are indifferent. And I think it goes down very deeply in how we are trained and how we are made to practice medicine. And this has been historical and it's global. It's not just, it's just here in the US. It's there everywhere. And we need to actually look at how we can overcome those barriers and those systemic things which are in place and how we practice medicine.
If I may, I'm not sure what the conventions are for wanting to speak, so I'll wave my finger. So, may I?
Please go ahead.
Lovely talk, Shahla. I was very impressed indeed. And indeed, with all the work you're doing, congratulations. I think one of the good things, one of the few good things that's coming out of COVID is an increasing recognition of the need for compassion, or I prefer to call it humanity, but it comes to much the same thing, I think. But there is a real, well, among the many problems that there are, one of them is this importance of not having too much compassion, as you alluded to in your own talk. We need to be trained to be able to have a certain distance, a certain self-protective distance, and also for the patient a protective distance. And I think that's gone over, it's gone mad in the development of 20th century medicine, so that's all that a lot of doctors have been trained to have. And their humanity has been squashed out of them by a whole lot of competing pressures, including indeed the awful pressure of time. If you haven't got time to be compassionate, you start cutting off. So I think one of the areas that you will be no doubt discovering in your investigations is that this is a real problem, but the question is then how to deal with it in a way that actually produces once again that balance between the equanimitas, as Osler called it, that's needed within medicine, combined with compassion and humanity of the good person. Anyway, that's a bit of a soliloquy on my part, but it's going to be quite a difficult balance to find, I think, within your investigations. I'm very glad that you're adding qualitative research for that purpose. Okay, yeah. I'll shut up now.
No, thank you. And I look to you for your guidance in that. I think that's why Kant comes into this, and I may have twisted Kant a little bit. You're the expert. I feel that and there is a thesis that I found from the Tibetan Center in the UK, which is actually leading ethics and morality. And they're actually looking at how Kant actually, what he meant by the duty of care, the deontological philosophy, was that actually morality is based in compassion and kindness. So the universal law that he spoke about was based on doing the right thing based on compassion. So it's not just feeling the compassion, but actually doing the right thing is more important as well.
Of course, there's huge discussion and controversy about Kant's philosophy. The traditional understanding of it is that actually he's devoid of emotion, and he's only interested in doing the right thing according to your moral will, and that's really the source of the criticism of Kant, is that he just wasn't emotional enough, aware enough of compassion and emotions. But of course, then you can discover counter arguments in the exegesis, and of course one of them is that if you're aiming to treat humanity as though you were a ruler over a kingdom of ends in themselves, or sometimes a republic of ends in themselves, as he sometimes puts it, then you need to think about each individual, and in a sense that brings it much closer to other ways of thinking about ethics. He's normally, of course, respected for his emphasis on autonomy, but I think basically what he means by autonomy is morality, your ability to make your own decisions within your perception of the overall moral law. But one of the interesting things I've discovered is how many different ways of doing ethics there are, and then trying to find some common norms, as it were, that belong to all of them. So I'm a great, as you know, principlist type, Beecham and Childress and all that, because I think they've discovered or identified 4 prima facie moral concerns that actually all of us in medicine, but I increasingly think all of us interested in being moral agents, can share. Yeah. Anyway, I'll stop now.
Thank you.
If there's no other question, Shahla, I have a question to you. Yeah. So how much of this is true that production pressure, which is so common in US and also probably many other locations, is a component? Production pressure and your requirement to fill in having these records, putting these records properly, having this electronic documentation, how much that takes away your time from what you really want to do, that is being compassionate. Yeah. The reason why I bring this up is because there was an article in New England Journal of Medicine last year that actually COVID was good because a lot of these requirements were lifted, that electronic documentation, etc., were not really forced on doctors, and they really found some time to be themselves, which is being truly compassionate. Is this a valid argument?
I personally don't subscribe to that argument. And the reason I don't is because when I moved back and started doing the EMR in the ICU, I'm still able to complete my notes, and I'm still able to practice medicine the way I did, the way I think should be done. And I feel that if I'm calling every family every day in the ICU, if I'm talking to every family that comes to the ICU, if I'm present in the ICU throughout, I feel that those things can be done. Of course, they are a hindrance, they're a nuisance, but it's all about time management. And if they weren't there, that would be great. But I feel that it's about priorities. So, your note doesn't have to be very detailed. It can, the resident has written the note. There are ways that we can write an addendum, make it meaningful, and just move on to what really needs to be done. If there is a dying patient in the ICU and their family are standing there and looking lost, I would rather spend the 45 minutes talking to them than taking care of my note and making sure that the coder gets all the words in so they can pay our hospital. I think that's important, but that can be done at a different time. So it's like you micromanage everything in your life. It's about priorities. So if you are able to do that, and so far I'm able to do that even before COVID and during COVID, I think it can be done. It's how much weight you put on human connection, talking to people, being there, and not just talking to people. Sometimes you don't even have to talk to people, but it's just doing the right thing by the patient is more important, and by their families is very important. So being compassionate, and we'll find out more in our study what people think and how they unpack compassionate care. We have scenarios where the physician is strapped for time. There are other pressures on the physician, other dilemmas that they have to face, and how they balance that. So we want to understand how people dissect this and what they consider the right thing to do is. In my daily interactions with physicians, there's very different perspectives of what compassionate care is. For example, decisions around end-of-life care can be very varying. And the ethical perspective is always the best perspective. And when I teach ethics, and I've learned that from Prof, is that ethics means ethos. It means habit. The Greek word ethos means habit. So ethics is something that clinicians must imbibe within themselves and their own practice as well, and not just delegate it to the ethics nurse who will come as a consult service. I feel that's very important.
Thank you. I'm just waiting. I have another question, but I just will allow others to ask if there's something. All right. Since no one is lifting their hands or chats, I liked how you said that compassion is a consequence of eliminating biases, right? Is compassion a trait that can be actually taught? Do you think you can actually teach compassion, or you have to go to the roots of why somebody is not being compassionate and take care of those issues? One of them is bias. So what is your, for example, at the end of all these investigations, you might actually conclude that there is less compassionate care and there is a lot of bias, etc. So what will be your next step to teach that to the younger generation? What will be your single 1 or 2 items that you'll focus on when you're constructing your educational mission?
So once, hopefully, we unpack what compassion is, I feel that it's teachable, partly it's like emotional intelligence or emotional awareness. For some people, you have to do a lot more work to get that out of them, even in our trainees. For other people, it's easy to bring about that humanistic aspect of their practice. You may just have to refocus where they are. And therefore, for me, and my second study that I talked about, Compassion for Peers, I'm focusing on a coaching model, which means that just like we focus on every patient differently, we have to focus on every clinician differently. And that doesn't mean you have to go and do an hour of therapy on every clinician that you have in your department. It's not possible, but there are different factors that every human being is made up of, based on their backgrounds, based on the biases that they come with, based on their experiences. But very quickly, when I do these sessions, I'm able to find out the perspectives that are important or valued in each person's demeanor, just by having a 5-minute conversation with them around a case, around a specific case vignette, which is deliberately difficult or has some underlying issues of interpersonal conflict or friction. And when you hear those, you can, and you are trained to look out for these things, you can pick up on those and teach and show them the literature or show them the other perspective, just like in the Chinese picture, the perspective of the other person. It very quickly brings about this change in them. And in that study, our qualitative data is showing that people are actually, when they rate themselves before the session, it's an A grade. They are A grade in their own assessment of their emotional intelligence and their compassionate skills. When we go through the session and they see the literature around the topic, for example, we had a topic about microaggression towards women. And we showed the literature and we discussed a case. And when they actually read about this and they heard the perspective of everybody in the room, then they went back and did the same quiz and they rated themselves much lower. So 50% decrease in how they rated themselves on the same quiz. So there is an enlightenment within themselves of where they stand with their compassion, their emotional intelligence, and what are the things that stop them. It could be, oh, I was really rushed, I was very busy, and this came out of my mouth and I didn't mean it. But it's something that now they are aware of. So I feel that a coaching model is important in teaching our mentees moving forward. And again, case vignettes always help because people can put perspective and real life situations in more, as more important than seeing a lecture or a module on compassion. That is not the way to teach. So for example, if I'm doing rounds and I am trained to look out for indifferent attitudes or attitudes that lack compassion, I can coach my trainees better and say, look, this is what happened. Let's have a debriefing session. I won't call it feedback, but like everything else, it's very cliched in medicine. It's got a negative connotation. You give feedback only when you are upset with somebody. But I would like to coach my trainees and I would like to win their trust, because if you have their trust, they will listen to you as somebody who's there to help them rather than somebody who's just criticizing them and grading them.
Yeah, I'll take it one more step and I'll challenge you that intellectually knowing something that, okay, oh, shoot, I'm not really what I thought I was, that is okay, an eye-opener. But having that as your DNA, meaning doing that on a daily basis, how do you change that intellectual understanding into a behavior? Is that enough to do it once that you point out, okay, these are your deficiencies, but they may go back to the same a week after, a month after? How do you actually make sure that they don't default to those?
So it has to be a system-wide kind of, not just curriculum, but it has to be a message, just like fighting racism. You can do it at one level or one person, but unless everybody recognizes this, or unless there are papers published on it, or people recognize that, compassion is something that is lacking. If you ask families and patients, there is a huge, before COVID, there was a huge mistrust of the healthcare system globally. People don't like doctors, they don't trust doctors. And what is missing is this actual human aspect. And in order to do that, it has to come from all levels. We can do it, I can do it with my trainees, but the trainee won't stay with me for more than a week. We can start building it into our curriculums. We can start looking at it as milestones. But I think it has to be a greater message. It has to come from the healthcare system itself, from not just trainees. I think we focus too much on our trainees. We don't focus on our faculty. So you have people going around and actually dispensing care to the families and their loved ones who may be indifferent, who really may not care, but we are still promoting them and we're still giving them rewards. And that whole system has to have a sort of reckoning, especially after COVID, and looking at what are the values that people really want to see in healthcare.
One, if I may say a couple of words. My name is Dwight Sladen. I've practiced intensive care for 45 years, no longer, but I had the privilege of having Shahla train with us almost 2 decades ago. And
just you gave away my age.
Shahla, you're very brave. I'm teasing you a little bit, but I see you walking around with a big suitcase that you're unpacking. You're unpacking a lot of things here. It's very complex. We live in a country which is transactional in just about everything that it does. And it also creates great opportunities, but it creates great injustices as well. We live in a country which is the only one that I am aware of that actually talks about the healthcare industry. And it really is an industry. It's a huge financial industry. It doesn't exist really to benefit its population. It exists to benefit the system. And that's why I think you're so brave, because one can talk about compassion on an individual basis, but one also has to talk about compassion on a societal basis. And one also has to be very careful about putting labels on everything. You know, you can't be compassionate without empathy. They're very different. The only way you can actually develop compassion is to put yourself in somebody else's shoes. And I think that's really important. And the one word that I would bring out here, which is absolutely constant to everything that we need to do, is the word respect. Because I think what governs our professionalism is a respect for each other, a respect for our patients, and a respect for everything that everybody does. And I know you're talking about compassion for your peers, but one needs to have compassion for the person who's sweeping the floor, the person who's trying to get through the rounds, bringing the food. Everybody is so focused and under such enormous pressure to do their job. It's really quite extraordinary. And then one final thought, and that is that, you know, again, because this is such a transactional society, the pushback you're going to get from compassion is, well, what benefit is it? You know, do the patients do any better? Does the hospital make any more money? Are the outcomes any better? And so that's something that you really are going to be dealing with. And then finally, I think, as you've alluded to, I think it's really important not just to think in terms like compassion, but action. You know, break things down, as you were alluding to. What are the actions that really are really important in terms of, first of all, serving as a role model for your trainees, because that's really where it starts. They become faculty later on. But also what you have to ultimately do is convince the institution and the society that what you're trying to bring back to the practice of medicine is something that's actually beneficial to everyone. And, you know, the way you do that is to publish, which is really what you're trying to do. That's why it's so important. But I would counsel you to go one step at a time. And, you know, I think you're doing it the right way. But it's important to have realistic expectations of what one can accomplish. I think in one's day-to-day work, to me, the most important aspect is to show respect. And you know, one of the things that I was very conscious of during much of my career is how patients become depersonalized. It's like a patient is a different species. You know, there will never be a patient. That'll never be us. One of the things that really would enrage me is when a resident would present a patient and talk about this player, as if this was somebody on a, you know, some kind of Ouija board. It's really quite extraordinary, the things that you will need to try to have to overcome. And I would just throw in respect, because people understand respect. Compassion is a very complex term, and it's you know, when you send out your questionnaire and you say to someone, do you have compassion? What am I supposed to have? I don't have any frame of reference for that. You know, am I compassionate compared to what? In fact, I would push back and say the only one who knows whether I'm compassionate is my patient. That's the only one who can actually give feedback as to, is my doctor behaving with compassion? And quite frankly, I think a lot of it is my doctor treating me with respect, with transparency? Does she or he appear to be caring? Am I getting the big picture of what's going on? And these are all action items that I think you need to foster. But at the same time, I'm really, you know, I am so proud of what you're doing, and I really laud what you're doing. You bring the essence of goodness to our profession, and that's something that must be fostered. So thank you so much.
Thank you so much. And like you said, you taught me a long time ago, but you didn't just teach me. It was the role modeling is very, very important, and being an essence of dignity and compassion yourself. It makes a big difference to how you train your trainees. So what Bala was saying, that how do you teach it? I think you have to imbibe it, and you have to walk the walk and talk the talk. And trainees learn, and they look at you more for how you conduct yourself, especially in the ICU. I actually have people looking up and staring at me while I'm talking to families. And I remember myself doing that with Dr. Slayton. You learn a lot of the things, and you actually put away in your mind, okay, I'm not going to behave like this. So you actually take negative feedback from your interactions as well. So trainees are not as naive as we think. They're not like this young and impressionable people who come to us and they will be taught anything we want to teach them. No, they will pick and choose. So if we bring about this person who's showing vulnerability, who's showing dignity, and who's showing a connection, you can have, like I have nurses, I have medical students who come and say, please, can we just sit and watch you talking to the family members? And I'm wondering, why do you want to waste your time? Why don't you just go and do something like put a central line in or something and just let me do my own thing? But these are the things that they value. And that teaches me that they are not the 13-year-old kid that I think my son is. They're actually adults, they're doctors, and they're professionals, and they want to learn things. So humans, I always give the benefit of the doubt. So even when someone's misbehaving or acting badly, I always feel that they're good people, they're in bad circumstances or something has happened. And if you try and understand their vulnerability and show your own vulnerability, I think it makes you feel better yourself, and I think it helps them. It's something very, very simple, very innate in ourselves. And I totally heed what you're saying, and I'm sure I'll make not much impact in the world, but I think this is something that is calling out to me, and I need to do this. So,
bravo.
Thank you.
Okay, great. Thank you, everyone. So if there is no more questions, in the interest of time, I think we have to close the session. So thank you so very much, Shahla, for this wonderful talk, and everyone else. Thank you for joining us and for these lively discussions. We hope to see you in our future speaker series. Have a good evening.
Thank you, Shahla. Thank you, everyone.
Thank you, Shahla. That was fantastic.
Great session. Thank you very much.